Good afternoon, everybody. This is a slide session that goes for 1 hour. I'll just condense it for within 10 minutes. This is just about setting up a low vision service. I'll just run through some of those slides. This is Helen Keller, who had been doing a great advocacy for the people with vision impairment, and this is a Perkins School for the Blind, where she was trained to help the people with vision impairment. In fact, this is a school where she learned the deaf-blind program, and this is a Perkins School for the Blind where she was trained, and this is her teacher who taught her the deaf-blind program. It is very quite popular there. In the early 20th century, this was a myope school. This was one of the earliest schools which worked for the people with vision impairment. This was Hoover, who worked for the blind, who developed the blind cane technique. And this has got an international color coding. Those canes with a white and a red color means that the patient is deaf and blind. If it is uniformly white, the patient is blind. And these are some of the non-optical aids called as the typoscopes. And this is called as a signature guide. And Lighthouse is one of the first non-governmental organization in USA which worked for the vision impaired people. Similarly, in India, the first low vision clinic was started at the government Skin Hospital, Madurai. This is the first pioneer in setting up the low vision service. And this is Eleanor Fay, who coined the term as low vision, because previously people were all termed as blind, even if they had a low vision. And just looking at the vision history, this is Herman Slenland, who developed the Slenland's chart, and this is Ian Bailey, who developed the Lagmar chart, and this is what we are following in the low vision clinics. William Flynn Bloom is again one of the pioneers who developed one of the fantastic low vision aids called as spectacle mounted telescopes, and this is one of the prototypes of the earliest CCTVs that was developed. And looking at the historical background, like people were thinking that in the early 19th century, like residual vision only can be preserved, but it was only in the later part of the century that we thought of vision enhancement. And looking into the low vision optics, here you will see, I'll just skip this statistics. This is one of the scenario which shows the distribution of the low vision services, and we can see an uneven distribution of low vision service from the north and northeastern part. And if you look at the definition, vision less than 618 up to light perception, and a field of view less than 10 degrees is a low vision definition. This is a Hong Kong definition. Just coming back to those different types of magnification, I'll just give a brief example. Here you will see an old man using a low vision aid. It is called as a stand magnifier, and he is using a reading stand. There is a light. This is a typical way we set up a low vision clinic and help the vision impaired to see. This stand magnifier has 24 diopters. We call it as a Sitzets cutaway stand magnifier. And he is using a spectacle also. And this is an example for a large print book, or called as when we improve the magnification, we also increase the font size. You can also subscribe for a large print, Reader's Digest. Here you can see a lady using a hand magnifier. The image formed is at infinity, so usually the patient need not wear a spectacle addition. This is an example for an electronic magnification where patients use a CCTV, where a camera is mounted and then connected to a AV socket of the TV monitor, where you can see enlarged magnified image. Looking at the contrast sensitivity of the patient also is very, very crucial, because SITS alone is not doesn't give us more information. And low vision aid services is more comprehensive. It is not just dispensing optical aids alone. We have to combine the non-optical aids like light, giving up signature guides, helping the patient to bring back their own life, giving some tips on the environmental modification, particularly patients with retinitis pigmentosa will require more lighting in their living environment, giving a rehabilitation guidance, giving a career guidance, patients with somebody who has lost the vision, somebody who is like a driver, we have to ask them to shift their vocation to some other vocation like which is easier for them, which is stationary. So those are called as a vocational guidance. And low vision aids, usually we can divide that like optical aids and the non-optical aids. The one used for the distance is the telescopes and the binoculars. The one used for the nears are called as a prism, aspheric glasses, magnifiers and the CCTV. And the non-optical aids are the typoscopes, noteheads or the reading stands. So it's a combination of optical and the non-optical aids forms the low vision aid prescription in setting up a low vision clinic. These are called as a non-optical aids. And the field expanders, this is reverse Galilean telescope. Generally, field expanders practically has no use on a day-to-day life, but still theoretically it has been explained. A high minus lens, a minus 20 diopter lens, if you hold it before the eyes, will compress a field. A Fresnel prism, a reflected mirror, a door eye, all these are called as a field expanders. Here you are seeing a 15-year-old boy with a dead mode syndrome. Initially he had a very good vision, but slowly he lost over a period of time. And here, in fact, even with this poor vision, his mother used to read the textbooks for him, and he had scored a very good marks in his 10th examination. After that, he could not continue his studies, and with the help of a CCTV, he was able to read his textbooks. So that is how low vision aids will help students, particularly in their school and college career. And looking at the LVA trial, this is how usually we go around patients around 6/60, a general high at bifocals will do. Patients from 660 to 3/60, usually I give a trial with the prism glasses with +5, 8 and 10 diopters because these are not continuous powers. And we can also give trial with the spherical lenses with +16, 18, 22 and 24 diopters. Apart from that, we have the hand and stand magnifiers. If the patient doesn't improve with all these things, we go for electronic low vision aid called as a CCTV, which will be less than 3/60. And the only low vision aid available for the distance is a telescope. But recently we have got this sort of a Galilean telescopes, which need not have a telescope appearance, but these are just two spherical lenses mounted, and there is a small space that is separating. This works like a Galilean telescope. This will be an excellent low vision aid, particularly that I am practicing in my low vision clinic for the distance, and particularly I used to give a trial for the children who wants to look at the board. The only thing is that we have to cosmetically convince the parent and the teacher that this sort of low vision aid can be used. And eccentric fixation is very, very important for the patients with macular degeneration. Here you can see a patient with macular degeneration fundus fluorescent photograph, and you can see those stars at the margin of the macula. Those are called as the PRL, or the preferred retinal locus. It's very, very crucial as an ophthalmologist to train those patients with the macular degeneration to use this eccentric fixation. So unless you train them, it's very difficult when they use the prism or the whatever low vision aid we give. And there are ways to map this eccentric fixation also. This is the typical Lachman chart that all of us use in our day-to-day life. Near vision formulas, what we use is a Kirschenbaum's rule. It's very simple. If the patient is having a 6/60 vision, the reciprocal 60 divided by 6 will be 10 diopters, and that will be the near vision aid that the patient requires. You can either give it as a +4 aid and give a hand magnifier with the 6 diopters. That 4 plus 6 will become 10 diopters. Or you can give a simple hand magnifier. There are a number of formulas, but this is the one that we generally use in our clinic. And albinos, it's very crucial that we give a tinted glasses. So, in conclusion, these are the conditions where all stationary conditions, they will be benefited with the low vision aids. All progressive conditions, we have to have a guarded prognosis. I will come back again on how to give an instruction with the low vision device. Thank you.